Everyone. So I'll give everyone just a minute to jump back in before we get started. All right, so I'm going to get started again. And so just welcome for those of you who maybe weren't able to attend the previous presentation. Today we have Julie Stratton, who just presented. And next we have Dr. Andrew Pinto. Hi, Andrew, great to see you again. And so I'm just going to do a quick introduction on Andrew. And then I think it's going to give you power to share your slides. So that would be great. So yeah, Dr. Andrew Pinto is the founder and director of the Upstream Lab. And the Upstream Lab is a research group focused on integrating health and social care, population health management, and using data to enable proactive care. He is a public health and preventative medicine specialist and family physician at St. Michael's Hospital and associate professor at the University of Toronto. He is the associate director for clinical research at the University of Toronto, practice-based research network, Utopian, and the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. And so just a reminder, if you can see the question and answer, if you can type your questions in there, and I will pay attention a bit more to the chat window as well. So when we ask questions in the follow-up session with Andrew, I'll check both sections. So but ideally, if you do have the Q&A, if you could type your questions there. Thanks so much, Andrew, and I'll turn it over to you.
Thanks so much, Marcy. And I just want to say thank you to the organizers for inviting me to speak today. It's a real privilege. And I should note that, although I'll be presenting, it's really on behalf of a huge team of people at the Upstream Lab and many of our collaborators, patient partners, and colleagues who are part of the various pieces of work that I'm going to share today. I'm just going to begin with acknowledging the land on which I'm meeting and based in, which is in Toronto. This is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And I'm very grateful for the opportunity to live and work on this land. And also, as part of acknowledging the land, as part of that, I try to highlight work that's relevant to the topic that I'm going to be speaking about, in this case, around data. And I want to just really highlight this fantastic paper and report that just came out just a few weeks ago. Includes an international team of folks, but including Robin Rowe, who's a stellar PhD candidate at Laurentian. And I really encourage you to take a look at it. It really speaks to Indigenous people's data during COVID and has these 5 recommendations around the collection of data and also its use, and really the importance of principles like OCAP around its use. So this is the Upstream Lab. We're a diverse team of folks who I'm just one of many people. We have a great group of graduate students, staff, and many others involved with our work. We divide our work into these 3 buckets. So work that we've been doing over the last 5 years since we've started around integrating health and social care and taking action on social determinants, population health management and how we can do a better job in this area, and also how can we use data and other pieces of evidence to engage in more proactive care as well. We do work, and I'll talk to some of the things we're doing around addressing the social needs of individuals, of patients, and of communities. Work on data, which we'll be talking about quite a bit today, as well as part of building a more proactive system is also engaging in education as well. and then also moving us to shift health organizations from kind of an individual focus to thinking about the population they serve. And I think in Canada, we're actually well along in this process. But we're in the early days of thinking about things like community accountability, and then also even more upstream ideas of how the work that we're doing to address and improve health is also tied to things like democratic engagement, policy interventions, and our social infrastructure as well. This is one framework that may be helpful to kind of make this more concrete. We published this in Canadian Family Physician a few years ago around how can health organizations engage in tackling the social determinants of health. And you can see it starts from data. And at the very top is this idea of robust and routinely collected sociodemographic data from individuals. This can be combined with the health data that our systems generate through our day-to-day work. It can be combined with health service data where we look and see how patients are using the health system in other areas like the hospital or social care or home care. And then also data on the community in which people are living and working and really their lives are embedded. And so what can this data do? So, and this will be a theme you hear me repeat, it's really about multiple levels. Data can be used at the individual care. It can change the care that I as a physician or as a health provider provide to people. It can lead to changes in how we manage my own practice or small community of patients. It can help me with identifying hotspots or where are we missing people in a consistent way. And where also, and we'll come back to this in a bit, where are we seeing evidence of systemic racism? We can also use data to drive change at the organizational level, changing business practices, how we offer our services. It can also then flow up into system evolution and changing who we build relations with, and then also upstream to advocacy, to actually advocating for policy change, which is really ultimately what shapes social factors. So to focus in on sociodemographic data, this work has really been going on for at least 10 years that I've been involved with it. And one of the starting points is this report, which was from an initiative called the Tri-Hospital plus Toronto Public Health Equity Project. It came about when people in different hospitals in Toronto started to come together and say, what we would really benefit from is a common set of questions that we administer to our patients to understand who we're serving and also to identify differences in outcomes. And I really want to point to the leadership of the people around the table at that time back in 2010, and particularly someone who's a really incredible person in the space, Camille Orridge, who is the CEO of the Toronto Central Local Health Integration Network, or LIN, at the time. And she, and I keep thinking about her words in this about data being important for accountability. Data alone is not going to create change, but it is one piece of looking at accountability and holding institutions to account for how they treat individuals differently. We were part of this pilot, and I was involved with this as one of the PIs. And we started at St. Michael's Hospital, which is the hospital which I practice as a family physician, started to collect this information within our family health practice, which is now grown to be a family health team that serves about 50,000 patients in the downtown east part of Toronto. So we learned a lot through this. I think one of the key findings was that patients, when asked these questions in the context of their care, and particularly within primary care, were not opposed to answering these questions. They actually understood that if the data was being used to help identify who needed what service, they were open to that. So we published some work on this, and then we got some funding from the Toronto Central LIN to study in more depth after a few years had passed. And we published a number of papers around patient views of collecting this data, and also really how good were the questions, how accurate were they. We learned a lot, and we then actually proposed some changes to the questions. And I think actually in what Julie presented, you see some of that reflected in what CIHI is produced, and over the last several years. It's really influenced our work, and I think our work has influenced their work as well. But certain things have changed. I'm going to now go over kind of the questions as they've been updated. And we then went on to actually test this updated form of questions in 5 primary care clinics. And we learned a lot about them and about the implementation. We've made some further modifications, and now we're going to be testing the psychometric properties and validating these questions that I'm going to share. Just before I get into it, just want to keep this in mind. One of the things we heard from patients when we interviewed them, and I think this has been consistent over many years, is really when we ask patients, they very much feel that this data should be used to influence their care, should be used to intervene at the point of care. It should influence the type and quality of care that they receive. So that's been a central thing we've brought to these questions. At a second level, it can be used at an organizational level to help design better services, to adapt services, to deal with issues at an organizational level, and also engage in quality improvement. And then kind of at a third level, this data can be used for health system planning, to identify systemic inequity, to make decisions about funding, and also it can be used for research, but it has to really start with the patient at the center. So we received a large grant from Canadian Institutes for Health Research to carry out something called the SPARK study. It is in collaboration with many organizations, and we've received in-kind and financial support from other organizations, and it involves colleagues in Saskatchewan, Manitoba, Ontario, Nova Scotia, and Newfoundland. And we have wonderful folks advising this work, including from Canadian Institutes for Health Information and other groups as well. The objectives of this work are to develop and validate a standard tool for sociodemographic social need data collection, evaluate the implementation, and then kind of somewhat separately now is a randomized controlled trial around addressing social needs. So getting into some of the questions, and I really would be interested in what people think. Again, you have to see these are questions that would be used in the context of clinical care. So they would be asked of people routinely when they come into clinics and are registered. So there is an aspect of these questions that you may see they don't have the same language or kind of cadence as, say, a census question or a question on something like a research study. They're meant to be to achieve multiple goals, improving care for that patient, but also in aggregate being used at the organization and then at the system level. So interestingly, with the original Toronto Central LIN questions, which asked people what language they would prefer to speak with their provider, almost everybody, even in a very diverse city like Toronto, chose English. So we're testing now this different question more about translation and would it be helpful. Immigration status has been fairly straightforward and fairly easy for people to understand, and this has not changed very much. One thing is, of course, it doesn't distinguish between people's legal status or identify people who may have been born in Canada, but then they quickly moved to another country and essentially grew up in another country. So there's some limitations to this, but in general, it's performed really well. One of the biggest areas of focus now, I think, across Canada is around race and ethnicity. And we moved to kind of informed by the work that CIHI has done and work that we've done. We've moved from a question that combined race, ethnicity, and geographic location to now this question. And it really is actually based on the Ontario Anti-Racism Directorate, standard that they had proposed. And one of the, I think, key things is actually conveying to a person who's being asked this question that this is not about differences in genetics, but the fact that our race and how we're perceived has important consequences. So right now we're at the point of engaging in validation of this question and asking people their thoughts. So we'll look forward to seeing how that goes. Sorry. And I'll just a note here that really much more work is required on Indigenous perspectives on posing these questions in health settings. And that's definitely something that needs to happen. And I'll come back to this point about governance and sovereignty and community engagement as well. Another area that has evolved is around asking about disabilities. So it's evolved to this more specific set of questions about challenges that people may face and how it would impact actually the type of care that's provided. And it's evolved from a previous question that really brought together many different things from chronic diseases to stigmatizing conditions and functions. So it's changed, and we have published a paper that describes kind of our journey to this question. Another area, again, which I think there's been a really great interplay with CIHI has been around an evolution of the question on gender identity to this two-part question about sex assigned at birth and current gender identity as well, and that's evolved. Also, the question on sexual orientation has also evolved and changed as well. One of the other kind of important aspects is separating out sociodemographics from social needs. And the idea behind this is that although there's certainly overlap in these concepts of our sociodemographics and our social needs, the idea is with these questions that there is something that the health system could do to actually help patients or individuals with these areas. And this ties into work we've done at the Upstream Lab around helping people with these different areas. So one kind of key thing that comes up is the question on income. Instead of directly asking people about their income, which many organizations have found and our research has found, people are quite reluctant, and they also actually find it hard to report on their income over the past year. We've replaced it with this question about having difficulty making ends meet, which in a British Columbia study has been found to be valid in terms of identifying people above or below the poverty line. But we're now kind of conducting some further validation of this question as well, with the idea that if people do identify they have difficulty making ends meet, there are actions in primary care and in health settings that could be taken to help people with their financial security and income security, but also it allows you to dichotomize the population into those who are expected to be above or below the poverty line. And I will say throughout this, there certainly is going to be clustering of how people respond around these questions. So education, income, prescription drug costs, housing, and that condition, including stability and ability to pay rent, social isolation, which is a really important area right now, transportation, and utilities as well. One area that people may wonder why it's not there is around food security, and that's in part because there's actually already a set of validated questions around food security, a two-part question that exists already in that area. So I guess some key insights from what we've done so far, and this is certainly a journey that we're on, and I will be the first to say I have much to learn in this area, and we have much more work to do. But I do think that we can achieve consensus on questions across organizations and jurisdictions. And I think we are coming to a consensus around these that are, again, the idea of a set of questions that would not only work for patients and clinicians, but also if they're administered across the population, really help with that organizational and then the system level picture. the questions are really never perfect, and we can spend enormous amounts of time with it. We do need to think about how questions evolve. Even in the decade that I've been doing this work, language has changed around many of these areas. But we need to strike this balance. Implementation is perhaps the greatest challenge in this area. And I haven't spoken much to that, but essentially our work to date really finds that this is absolutely key. And really what we find is if leadership is supportive, staff are trained, and patients really understand why, and there's trust in the organization, particularly around privacy, generally patients will respond to these questions. Just a point about collection of data on race during COVID. So early in the pandemic, many people in the spring of 2020 were really noting how there was a differential impact of COVID on racialized communities, particularly work from the US, where they collect data routinely. And so early on, the Upstream lab issued this report, and I think it's had some impact on Canadian thinking, along with many other voices that were also calling for this type of data to be collected. One of, I guess, our key things was it should be collected along with other social factors such as income or housing or occupation. We really tried to encourage that there be the same question across provinces so we could compare. It's really important that there's a preface for understanding and that staff are trained, but really key is transparency around the use and engagement of communities around this. And CIHI issued its report in May and subsequently discussion paper after that in July or so. And it's really informed, I think, people's thinking in this area. Just an example of how the data was used very early. So after hesitation and reluctance, the Ontario public health system did move to mandate the collection of data on race during COVID. And it was used very quickly by public health units in Ontario to demonstrate the disproportionate impact. This is just one example from Toronto. And there's really great examples from Manitoba as well of how this data has been used to inform the response as well. I would say that it's definitely a journey, and there's a long ways to go to where this data is collected and it directly informs what happens in a public health crisis. Just a really important framework, and maybe someone can put this in the chat as well, the website here. But this was something that I had the privilege of being involved with, which is called the Black Health Equity Working Group. There's a group of leaders in Ontario really who came together to talk about a vision of what does community data governance look like around this data. And COVID was really a big part of the impetus, but these have been thoughts that have been circulating for a long time. And so it's very much a framework, and a lot of feedback was received by community and by other groups around this. But the idea of looking at engagement that is genuine, ongoing, and transparent, governance around the use and interpretation of the data, access, which is a really important area that communities actually have access to their data, and protection of it. And this is a really new concept in some ways in Canada, the idea that individuals' information, not only is there an individual responsibility around protecting it and using it in an appropriate way, but also that there is a responsibility to diverse communities as well. And there's a community accountability and responsibility as well. And so I'll just mention this in the context of something that we're rapidly all witnessing the evolution, which is really looking at the role of data and AI methods that process this data on health and healthcare. And this is just a collection of reports over the last year or two from Canadian health organizations. You know, there's this really, I think, optimistic view of the potential of AI applications. that people have put out, but there's also these concerns really about AI and what the potential is. And many folks have actually brought up the dangers and concerns about these applications, particularly to reinforce bias and systemic racism if these are not considered beforehand. And just like there are many examples now, but this is just one that kind of was highlighted early on in 2016 by ProPublica of bias in an algorithm used around sentencing in the US. But this is something that has been very much identified within healthcare applications, and certainly this type of data that we're all talking about collecting could actually further this as a major problem. So what are some of our next steps in this area? So one is we are conducting a study of the psychometric properties and also collecting in-depth people's perspectives on the collection and use of this data in a number of provinces. We're also, with collaboration with CIHI and others, working to validate these questions against, for example, census questions. And I think after these two parts, really, we will have a very good tool that is fit for purpose in routine healthcare settings, and that's something that we can trust. Not to say it won't continue to evolve, but I think it will be a good point that we're at. And then we'll be engaging with a number of clinics around implementation in primary care and really aiming to look at how that can be done. And we recently were funded by CIHR to do some work around mitigating and identifying bias in machine learning as applies to population health. So you can see how these different streams of our work intersect, and we're trying to be both very reflective and mindful of some of the challenges, while at the same time working towards the idea of using data around accountability and improving equity. Just some points about these are kind of our top 10 so far of really key considerations or core principles around data collection in health settings. So the idea of committed leadership and staff is central. Ensuring Indigenous data governance and sovereignty over the data. Community engagement around the data, as I've talked about. Transparency. Taking action, and this is perhaps one of the key things, which is ensuring that it's not just data collection. We've already seen examples where where health organizations just collect the data, and it seems like almost like that's they feel they're doing something about the issue. There's a really big need around continuous data quality, which all of the epidemiologists and biostatisticians in the audience will know, but something that if we don't put it into this, it doesn't happen. There's a key area around staff training and also quality assurance around that training and making sure people are kept updated and engaged in the actual reason the data is being collected. Communicating to staffs, which could include even like how we have signs in clinics and the type of even signals that we send to people that we're interested in this out of a sense of trying to achieve equity. There needs to be a process if people feel they've been discriminated against, that's clear. And absolutely around other personal health information, key issues around data security and privacy as well. So I'll stop there. And, if you'd like to follow our work, really our newsletter, which comes out once a month, is a good way. And happy to take questions as well. Thank you.
Great, thanks so much, Andrew. I'm just going to take my video off here. There we go. Thanks so much for the principle, because that actually ties into a lot of what I've been thinking about with the working group, and particularly how to stop, I guess, to stop focusing on the measuring, but really how to address inequities, right? So I really think that gets to the heart of it. There was a question in the chat earlier around how to ask, there's two questions that actually I think tie into the principle. One around the principles was how to collect data if providers are hesitant to ask some of these questions. And the example was given around gender. And so do you have any suggestions around that, I guess?
Yeah, that's a great question. I guess a few things. The work that we've done to date has really been where people are given the questions and that they're self-administered rather than a member of the healthcare team asking the questions directly. And this actually back in 2010-11, a review that was done of the literature at the time to inform the Toronto Public Health and Tri-Hospital project found that would be preferable, as people having the chance to self-administer the questions. There are definitely, caveats to that, like in the context of, say, an inpatient environment where people may actually be unable to answer the questions because they're so unwell. But in general, we've been really thinking about where people self-administer the questions. But what this question is getting at too is, what about where the leadership or providers are not on board, or and that I think is a key issue. I think there's a baseline level of engagement and commitment and understanding of the terms. And the reality is, in many health professional training right now, there's a fairly limited training on diverse areas like around gender identity and sexual orientation. And that needs to be part of the process too. There's a reason, a few years ago, a study in Ontario found that a large proportion of gay men were not out to their primary care provider about their sexuality. And so, like, thinking about that and keeping that in mind, it's really important to ask why that is, and therefore, is this appropriate to ask this of patients, and what needs to happen on both the provider side, but also the clinic side, to create spaces for people. That's what one of our current studies is asking people about. What do they feel about these questions? What would they need to see to set the stage for them? And also, what are the really important assurances around data security that would need to be put in place around it as well?
Great, thanks. Yeah, actually it ties into the work that we've been doing around the sex and gender working group and the planning project, and that really the need for cultural competency and the leadership, and then also the environment. So having signage around letting people know that it is a safe place to answer these questions, right? So yeah, it really reflects what we've found there as well. One of the questions I had actually that kind of ties into this is, if someone, I think on the race and ethnicity questions, you can choose multiple options, but how do you, if someone chooses multiple options, how do you actually report that when you're looking at like the graphs that you showed? Mm-hmm.
Yeah, so that's a common question that comes up, and I think there's several different approach to it. It's actually one of the things we really hope to explore too, which is for individuals to identify as mixed race. What would they choose, and do they see themselves in these questions? And there's also the option of people selecting multiple options if they have if they identify as both or as well. In general, what I think we're looking at is, with the information on racial identity, is really broad patterns of systemic racism. And so there's often with this information, we could use it, and what other institutions that have collected this data have used it for is actually looking at these broad trends, like the COVID example. And so, even though individuals may answer the question by selecting more than one options, in general, you would still see a pattern. I think, a big question right now, I think in our study group around this area is really, should that sort of information only be analyzed at the large organization or kind of population level? Because again, like we say in the question, it's not about individual differences in genetics or things like that. It's about how people are treated differently by organizations and institutions, including the healthcare system. And so really, is it necessary to link it to individual records or report on it? It's really more about the big pattern that's being seen, and also to track changes as well. One of the rare examples in Canada where we've seen this information collected and reported publicly and actually lead to strategic planning. If, I think they're not yet, we can't say it's led to action because it's really just been launched as their planning, is actually the Center for Addiction and Mental Health in Toronto, which has really been one of the organizations that's been thinking about this for a long time. And, to their credit, they publicly released examples where, for example, Black individuals were being treated much differently and in a much more negative way than others. And then it actually informed their anti-racism strategy that they released in February or so. So what I think we would want to move towards is where there is that transparency around the data, which is, I know, a big step for health organizations to take. And also really where it leads to action, there's actual measurement of that action, that it could be measured. For example, is the use of restraints actually changing for individuals who identify as Black? Is it going down? Is that an inequity that's actually changing over time?
Yeah, I've wondered the same too. Is do we actually need to have that data at the individual level, right? Or is it better to have it at a population level? It kind of ties into Finney's question that was asked earlier, but around how this relates to ethnicity. Do you see an ancestral background? I've also wondered about the term of cultural background instead of race and ethnicity. And do you see a difference between those?
I think they are really different concepts. I think, and I'm aware colleagues at Statistics Canada actually have been thinking about this for a long time, and there's a lot of media around the census that many of us got, and really their thinking, and the fact that they've actually been allocated a large amount of funding to specifically look into this area. But I guess my perspective is these are very different areas of cultural background, ancestry, and really what this question about race is getting at is fairly narrowly focused on the experience of how people perceive our race and how that changes how we're treated by different institutions, whether it's healthcare, the justice system, education system, or how we're treated within a workplace as well. So I think we can't try to capture everything in one question. And this is really, and that's why I think our preamble tries to make this clear. This is about how people are treated differently. We've gone back and forth about, should we just specifically say this is about systemic racism in the question we have held off, but we are going to, hear from participants in this study about their thoughts about that. But I think to try to just narrowly focus on that is kind of a good starting point. And then I think, some of the other areas about how, for example, our culture or background changes how we engage with the healthcare system, or how it influences our uptake of health promotion or medical recommendations, how it actually interfaces with our own cultural understandings of health. That's a huge area. I think this is just a starting point.
Yeah, great. One of the questions that came up, speaking about Statistics Canada, was, and I've noticed in your survey too, is for gender you have male and female, and same with sex. And so, have you shifted in thinking that it should be women and men? And
yeah,
I guess
I should say,
yeah.
I think that now actually we actually have updated that to man and woman.
Okay.
Exactly.
Yeah. And how do you, I guess, second part to that, how do you see a way to keep updating with the changing language with some of these areas?
Yeah, I think that area, and particularly the question about gender identity and sexual orientation, are two of the questions where there has been, over the last decade or so, a lot of changes in how, in the terms that are used. I don't know if there's any simple solution other than, I think there is a starting point, and then similar to big instruments like the census or the Canadian Community Health Survey, these things have to evolve and be updated. I think what would be quite neat is if there was a kind of a continually replenished reference group and community that advised on the language, but also helped guide the use around this data. I think that could be really neat. And whether that's at a national level or is more of a provincial and territorial level is I think something to think about. But the changing language and terminology is also, I think, really tied to the use and telling the story of the data, and ensuring that it's really the community that is telling the story around this. Maybe I just want a really great question from Annalyn that came up too, is about, should the question not be about people's experience of, if the question is really about racism, should not be about what people perceive you as, rather than self-identification. And absolutely, this is something that I think we've talked a lot about over the last few years about this. We've landed on continuing with how people self-identify, or specifically like which category best fits you. But I agree. I think there is over many decades, going back to the civil rights movement in the 60s in the US, there's been that debate going on that, is it really about how you identify, or is it about how people perceive you? There's for this work we've landed on self-identify, in part because we think that it's also about people sharing kind of their identity with the health system and who they are and how they see themselves. And so there's an aspect when we've done interviews with patients previously, which has actually been very affirming. In the paper that we published on the collection of gender identity and sexual orientation data, which was in CMAJ a couple of years ago, we shared that kind of the positive aspect for patients of being able to self-identify and say, this is who I am. So that's what's led us, but I very much agree that that really that it's actually a lot about how people perceive us and then how we're treated. The other aspect of this is by looking at these questions individually, we really are missing the intersectionality of different aspects of our identity and our position and how we're treated in society. So I think there's a whole nother area of work around how do we actually interpret differences, and that it's, to take the example of COVID, it's certainly not only about systemic racism as people have experienced and how it leads to who during this time has been able to work from home versus who hasn't, who is working in an essential job, job protections, paid sick days, all of these things that ultimately influence who gets COVID or not. But how that intersects also with gender and also intersects with immigration status and many other factors as well.
Great, thank you. There's a couple of questions on income, but one of the questions I also wanted to ask was just how you see, so you had mentioned, I didn't know about the food security part, so that's interesting too. Are there other aspects that you would bring in, and how do you see this, I guess, developing this as a value set for broader than the 4 provinces that you've been engaged with, I guess?
Yeah. So right now it's been these 5 provinces of Saskatchewan, Manitoba, Ontario, Nova Scotia, and Newfoundland. And really the reason for that has been because when we submitted this grant application, this project aligned really well with priorities that had been set in those provinces around wanting to engage in work that was tackling inequities and actually aligned around this area of data. But there's I think our findings certainly will be useful for others. I don't think that I think that what needs to happen in each jurisdiction is really the challenging and kind of crucial work around engagement around the data. I think that's where a lot of the work will have to be, as well as around and very closely related is around the implementation. So how it's like not enough to create the questions. That's just like the starting point. And I think again, the work that colleagues at CIHI have done and the work that many people have done has kind of moved that forward, and we're starting to see kind of a set of questions that we could live with, that is not perfect, as will continue to evolve, but it's really going to be about kind of the next step around this data. One of the questions that I just seeing, I want to just, I guess, touch on is around the point. Well, one, I think, simple question was around income and household size. And I think that's actually something that we've done with other work, is asking people about what is their financial status, and then also how many people are actually being supported by this income. Interestingly, that can vary a lot. There's a lot of complexity to that, because does it include people who are dependents but not in your household? Does it include things like remittances to family members abroad? So there's a lot of questions. Interestingly, a simple question like, do you have difficulty making ends meet, or are you having challenges, seems to capture quite a bit in it. And so there's a related question around that about, does it take into account where the respondent lives? And exactly, it's like, because of its kind of simple nature, it would actually adjust for costs of living in other areas. But this is where the validation study is coming in. So what we are going to be doing that to actually ask people this question and compare it to, for example, are they above or below the low income cutoff for their area, and then be able to answer that question.
Great. I'm just scrolling through to see if there's one question around, have you had any specific measures around cultural safety and humility? And I don't think you have yet, but
no.
I haven't seen it yet, but yeah.
It's a great question. It's a whole another area around that. Again, I guess one of the things to say is that these questions right now, they achieve one small piece of the overall puzzle, and it's not really it's not going to be all encompassing for everything. A few questions, I think people have also been using the chat as well. I think we covered that these questions we see as being self-reported and likely it could be at registration. It could be at a different point. And I should note that we're actually, although our work has been based within primary care, it's not, it's something that's starting to be taken up, and we're doing some work in inpatient settings as well with colleagues who are also interested in this work. Again, kind of keeping with that theme of seeing these questions being used for improving patient care, and then secondarily being used to identify inequities. But they technically could be used in other parts of the system, from inpatient to home care services, etc. There's a great question about asking these questions to children and youth. That is a fantastic question. Some of our early work that we did at the St. Mike's Family Health Team, where we had been asking these questions over about a 3.5-4 year period. The way it was implemented in that context was by offering it to everyone when they came to see their primary care provider. And staff had been trained to offer it to everyone, families with young kids, everyone. But what we did find is that systematically there was a responder bias, in that many young families did not have this information. When we did interviews with staff and did also observations in clinics, kind of not surprisingly, what's found is that if someone comes into their primary care provider and they have like a kid or 2 kids or 3 kids, their hands are full, and the staff are quite reluctant to add something more, like saying, here's a tablet, would you like to fill this out for each child? So it can, again, that issue of implementation being so central, and that it can be really, we can easily miss these questions. And then there is that question about, so for what age, so all of our work has been with adults, essentially, in terms of the in-depth interviews. I think a whole nother area of work is about posing these questions to adolescents who could answer some of them themselves, but that's not been an area that we've done work in as yet.
Great. I know it's 6 minutes to, and so there's just a couple of comments more, I guess, in the Q&A. So one was that self-identification is so heavily influenced by how one is treated. That's why ethnic identity is a fluid construct. And then there was a comment more about our question around, is it biased to referring to African and Caribbean who are geographically different as Black, whereas there are many Black Asians who are categorized as Asian only. So I guess that also ties into the question I had around how do you separate that out? So yeah. Yeah,
again, it's something that I think we'll be learning a lot about as we do this next step of the research. The Ontario Anti-Racism Directorate did consult quite broadly as they developed their question. But I think, of course, these continue to evolve. And I think what we have seen is actually a larger and larger proportion of Canadians identify as mixed background. And so being able to capture that is helpful. Again, I think this is why I'm really happy with the question, that we preface it really with this point about race being socially constructed, and that it's nothing to do with genetic differences, and really about identifying how we're treated differently by organizations.
Yeah. Well, thank you, Andrew. Yeah, I'll end it there so that people have a quick little break before we jump to the next session. Just really appreciate all your time today.